Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, we often think of the liver, heart, and diabetes as separate domains managed by hepatologists, cardiologists, and endocrinologists. But in reality, these three are not separate organs working in isolation. They are parts of a single metabolic triangle, deeply connected and constantly influencing one another. A fatty liver can fuel diabetes. Diabetes accelerates cardiovascular disease, and heart disease worsens outcomes in both. Understanding this triangle is not just about academic knowledge. It is about saving lives by seeing the bigger picture of interconnected health. Bismillah ar-Rahman ar-Rahim. Greetings from my institution. As said in the intro, we are discussing the liver, heart, diabetes triangle today. Let's define the problem. This chart shows the life expectancy in the world from 1955 to 2025. The blue is the male life expectancy. The orange is the females, and this gray line, it's the both sexes. In 1950, the life expectancy of the male were 44.5 years, while that of females was 48.4 years. And the combined life expectancy was 46.4 years. This was in 1950. What's in 2025? In males, the life expectancy in the world has increased from 44.5 to 70.9 years, and of the females from 48.4 to 76.2 years. And the combined life expectancy in 2025 is 73.5 years. It means we are seeing significant increase in the life expectancy in the world. Now the life expectancy is better as it was in 1955. And when we see the causes of the death of today, the red line is showing the causes of the death, top causes of the death in 2015, and the blue line is showing the top causes of death per 100,000 population in blue. And these are the different diseases. The ischemic heart disease, the stroke, the chronic obstructive pulmonary disease, lower respiratory infections, diabetes, trachea, bronchia, and lung cancers, the road injury, HIV and AIDS, diarrheal diseases, hypertensive heart diseases, cirrhosis of the liver, liver cancer, kidney diseases, stomach cancer, colon and rectum cancers, self-harm, falls, Alzheimer's disease and other dementias, and breast cancer. But we analyze these, what we see that the lower respiratory tract infections, no, they are less responsible for causing of the death. Same is for HIV and AIDS and the diarrheal infections. It means the increased in survival is because of the control of infections. But when we see the diseases like cirrhosis of the liver, almost the same. Liver cancer, this is going to be among the top causes of death in 2030, followed by the hypertensive heart diseases, ischemic heart diseases, and diabetes mellitus, and the stroke. So the good control of infections is leading to increased survival, but now the cause of mortality is going to be the liver diseases, the heart diseases, and diabetes. It tells that the liver, the heart, and diabetes, these are going to be the top causes of mortality in years to come. So this makes a triangle, the liver, heart, diabetes triangle. These three are the major causes aside for increased mortality now. And these are not discrete, remember, rather connected with one another. So they are not in isolation, they are connected with one another. The liver-heart diabetes triangle, it refers to the interconnected relationship between liver disease, heart disease, and diabetes. And this is fact. And we should not concentrate on only one component, one angle, one part. We should concentrate, we should look for the whole. We should have an holistic approach rather than tunnel vision. So the liver, heart, and diabetes triangle, let's explore the liver and heart connection. What does it mean clinically for we physicians? The impact of the heart on the liver is that the congestive hepatopathy because of the the heart failure, what we see the congestive hepatopathy, and this is seen in the valvular diseases of the heart, the cardiomyopathy, the left heart failure, and constrictive pericarditis. All these diseases, they lead to congestive hepatopathy, and similarly, the cardiogenic ischemic hepatitis seen in the acute decrease in cardiac output. So the heart can impact the liver, leading into liver dysfunction. And this is the data from the recently published trial. Similarly, the liver also affects the heart. How? The heart dysfunction happens because of the cirrhotic cardiomyopathy, what we see, the portal hypertension, the portosystemic shunting, impaired cardiac beta adrenergic responsiveness, and remodeling of the cardiac collagen matrix. So all these lead to cirrhotic cardiomyopathy. Another scenario is liver transplantation, and there's stress-induced cardiomyopathy. Then another scenario is the NAFL or MEFL, the big challenge of the current era. There's insulin resistance, there is structural subclinical inflammation, there's oxidative stress throughout the body, ectopic fat deposition, atherosclerosis, and endothelial dysfunction. All these leads to hepatic dysfunction. So the heart has impact on the liver, leading to liver dysfunction, and also the liver, different scenarios, different diseases of the liver impacts the heart, leading to heart dysfunction. So this tells us that disease of one organ affects the other organ. Now see the liver and diabetes connection. What does this mean to us? The global prevalence of NAFLD or fatty liver among type 2 diabetes patients is 55.5%. And it's a global problem. No part of the world is spared from this. The East Asia, 52%. The South Asia, we see 57%, rather 58%. Then in the West Africa, again, a big figure, 67%. Europe, 68%. America, 30.4%. Latin America, again, 56.5%. And the United States 51.5%. So the global prevalence studies, which were published in 2019 Journal of Hepatology, it tells that if a patient is diabetic, 55.5% of them, they are having MAFLD or fatty liver disease. Another study published in Clinical Gastroenterology and Hepatology 1999 and telling us the global epidemiology of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis among patients with type 2 diabetes. Again, the same. The globally, 436 million adults with type 2 diabetes, 65% of type 2 diabetes were having the MASLD, and MASLD in type 2 diabetes is on the rise. What we see in 1990 to 2004, it was 55.9%. This prevalence is increased to 61.7% in 2005 to 2009. And then 2010 to 15, next 5 years to 64.7%, and in the next 5 years to 68.8%, almost 69%. And this is again from the same paper, and the number of people having MASLD and type 2 diabetes in all across the globe, in every continent, it's there. And what we see here, that the percent of patients with type 2 diabetes who were having MASH, 66%, and out of these, 41%, they were having significant fibrosis, and 15% of them, they were having advanced fibrosis. Similarly, the prevalence of type 2 diabetes among patients with NAFLD, these were that if a patient is diabetic, how many of them are having fatty liver disease, or in how many the liver is affected. This studies, which was published in 2024, it tells us that if a patient has got fatty liver, how many of them they were having type 2 diabetes. And this was a study across 40 countries, and you see it's a global problem. The dark blue are where it was the prevalence was 15%. Then in the light blue, these were the countries where the prevalence was, the type 2 diabetic prevalence in fatty liver disease was 15 to 23%. In the light green, it was 23 to 31%. The dark green, 31 to 39%. This A part was the 47%, and the red was the 63 to 100%. And here is the data not available. So if a patient is having type 2 diabetes, he or she is prone to have the fatty liver. And if a patient has got fatty liver, presents with fatty liver, and when you look for the good number of them, they are having type 2 diabetes undiagnosed. So, and this is the across 8 countries, again, a very alarming figures that the people incidence density of type 2 diabetes. This was the prevalence, and this is the incidence, means when you follow up these patients, how many of these patients they develop type 2 diabetes. So how this happens? What is the impact of MASLD, the metabolic dysfunction associated steatotic liver disease and type 2 diabetes? MASLD promotes the worsens, the insulin resistance. So there's insulin resistance is increased. There's a high risk of atherogenic dyslipidemias. There's high risk of type 2 diabetes, increased difficulty to manage such patients, and there's increased risk of cardiovascular disease. And when we see the impact of type 2 diabetes on muscle, the diabetes promotes a high risk of steatohepatitis. It promotes the chances of steatohepatitis. It increases the risk of cirrhosis, and it increases the risk of hepatocellular carcinoma. So if a fatty liver disease patient is having type 2 diabetes as well, so the risk of developing steatohepatitis, cirrhosis, and hepatocellular carcinoma is really increased. Now coming to the third arm, that is the heart and diabetes. The heart and the diabetes connection are this arm. What does tell us clinically? We know the diabetes and heart disease, what's the connection? The high blood sugar can cause damage to the walls of the blood vessels, leading to, and this damage can increase the buildup of the fatty material here. And over time, the blood vessel narrow and blood flow is reduced. So this is we know the natural consequences of the hyperglycemia, leading to deposition of the fatty acids in the vessels and then the narrowing of the vessels. So when we see the orange part is the impact of the diabetes and heart on one another. The diabetes leads to coronary artery disease, and this leads to heart failure. Similarly, the heart failure leads to renal disease. Type 2 diabetes also leads to renal disease. And then the reason why type 2 diabetes affects the heart is because of the insulin resistance. There is dyslipidemia, there is hyperglycemia, there is family history and lifestyle. All these are the different promoting factors. Similarly, the heart failure because of the myocardial infarction, toxins and substrates, the idiopathic or arrhythmias or infiltrative heart failure or hypertrophic because of the hypertension or inherited or valvular heart diseases. All these leads to the renal failure, and the factors which are affecting both parts is the age, sex, race, hypertension, and obesity. And this article was published in the American Journal of Cardiology in 2019. So when this is again a diagram from an article published in 2023, recent articles, diabetes mellitus. It leads to diastolic dysfunction of the heart and systolic dysfunction of the heart, which leads to cardiomyocyte hypertrophy, leading to myocardial fibrosis, and this leads to heart failure. And here then there becomes the rules of GLP-1 and the SGLT2. So if we summarize, there's oxidative stress and inflammation in diabetes. So the hypertension, dyslipidemia, diabetes, aging, smoking, obesity, menopause, all these are associated with these. And over time, the intact arteries, the vessels, there's endothelial dysfunction, and this is the initial lesion. Then there is the fatty streak, and leading to atheroma and the fibroatheroma, that is the occurrence and development of the atherosclerosis. And then at the end, it's a complicated lesion leading to cardiovascular complication. So it's a cascade, it's a sequelae which starts from these risk factors and leads to the ultimate cardiovascular complications. So diabetes mellitus leading to hyperinsulinemia, and this is because of these two pathways, the P13 KNAKI1 and P3 MAP kinase pathway, leading to myocytes hypertrophy, which leads to arrhythmias and diastolic dysfunction, as well as it also leads to diabetic cardiomyopathy. The other way of damaging the heart by diabetes is the increased elderly age. There is endothelial cells of impact on the smooth muscle cells. So there is decreased nitric oxide concentration. We know nitric oxide concentration is the potent vasodilator. So there is a functional vasoconstriction leading to microvascular complications and ischemia, and again leading to diabetic cardiomyopathy. Similarly, in diabetes, we see mitochondrial dysfunction, and there are the ROS, and it leads to the extracellular matrix formation. Also, in the elderly, this is the end result leading to myocardial fibrosis, again diastolic cardiomyopathy. So the impact of the diabetes on the heart is multifactorial. It has got multiple pathways, and because of hyperinsulinemia, or because of in the elderly age, or the mitochondrial dysfunction, it leads to diabetic cardiomyopathy. The heart is affected in diabetic patient by different factors, and these include interleukin 1, interleukin 6, 10, 18, INOS, fibrinogen, TNF alpha, and CRP. All these are the contributing factors or players which leads to impaired heart function in a diabetic patient. And then the role of the DMPs and PMPs. The DMPs, it comes from the myocardial stress ischemia, and the PMPs, this comes because of the congestion and hypoperfusion of the gut. And all these leads to inflammation and inflammatory cell recruitment in the whole scenario. So the liver heart diabetes triangle, why this triangle is existing? The simple reason is because of the insulin resistance. This is the insulin resistance which makes this triangle, which connects these three, the liver, the heart, diabetes, and because of which these cannot be seen in isolation. They can be seen as the three aspects of the same problem. So, what about the insulin resistance pathophysiology? It has got a complex pathophysiology. Who are at the risk of developing insulin resistance? There are multifactorial phenomena. There's risk factors which are genetic predisposition. Then there are environmental and lifestyle factors. So if anyone has these risk factors, he or she is at the risk of developing insulin resistance. So let's understand what these factors are. In the genetic factors, these include family history. And it means there is genetic predisposition, and it plays a significant role in the development of insulin resistance. There are families where the insulin resistance runs in the families. The parents, the siblings, the grandparents, they just carry the disease, carry the genes. So genetic predisposition plays a great role. Then genetic mutations. There may be not genetic predisposition. Disease may not be there in the genetic, in the family, but in some individual, some genetic mutations happens. So mutations in the genes involved in insulin signaling like IRS1 and P13K, these also contribute to insulin resistance in that particular patient where the genetic mutations happens. Then coming to the environmental and lifestyle factors, these include obesity. The central obesity, particularly visceral fat, it promotes insulin resistance. So anyone who is obese, who has got central obesity, he or she is at the risk of developing insulin resistance. Then physical inactivity, sedentary lifestyle, it also contributes to insulin resistance. So if you have got a sedentary lifestyle, you are more prone to develop insulin resistance. Similarly, unhealthy diet. If you are consuming high caloric, high fat, and high sugar diets, again, you are at the risk of developing insulin resistance. Among the environmental and lifestyle factors, another is the stress, the chronic stress. It activates stress hormones and it leads to insulin resistance. So a chronic stress, if someone is suffering from, again, he or she is at the risk of insulin resistance. Similarly, sleep disturbances because of the shifts or because of some other commitments. If there is poor sleep quality or poor sleep quantity, poor sleep duration, it also contributes to insulin resistance. Some other factors beyond these genetic, environmental, and lifestyle factors. What are these? Hormonal imbalance. Hormonal changes such as polycystic ovarian syndrome and Cushing syndrome, they are prone to develop insulin resistance. Similarly, medications, certain drugs like steroids and certain antidepressants, they are associated with insulin resistance development. Similarly, chronic kidney disease, impaired kidney functions because of any other end cause can contribute to insulin resistance. So it's not only one type of people or one risk factors who are at the risk of insulin resistance, multiple risk factors, and the higher the number of risk factors present in any individual, higher is the chance of patient developing insulin resistance. So, because of any reason, if someone has developed insulin resistance, how it manifests? In insulin resistance, what we see, inflammation, generalized inflammation, inflammation in different organs, starting from the liver. Then there's oxidative stress. In the metabolism, there's oxidative stress in different organs. There's insulin signaling impairment, and there's adipokine imbalance, and of course, mitochondrial dysfunction. So these are the 5 main components of insulin resistance, and because of that, all these clinical outcomes we see. So there's inflammation, oxidative stress, insulin signaling impairment, adipokine imbalance, and mitochondrial dysfunction. First organ where insulin resistance starts. What is that? The answer to this is liver. Liver is the first organ where insulin resistance starts. So why? Why it's the liver? Why not the muscles? Why not the fat tissue? Why not the heart? Why not the kidneys? Why not the pancreas even? Why insulin resistance starts in the liver? And the answer is insulin signaling activity. This is at its maximum in the liver. The liver harbors the maximum insulin signaling activity in the body. Then glucose metabolism, lipid metabolisms. Maximum of the most part of these metabolic activities, they occur within the liver. And the liver has got unique vascular access double supply. The portal venous supply and the hepatic artery supply. So the liver has a unique vascular access. It has got the maximum amount of glucose and lipid metabolic activities inside it. And of course, the insulin signaling activity is maximally happening within the liver. And because of these 4 factors, insulin resistance starts in the liver first. What is the role of hepatokines? There is different hepatokines which are associated with insulin resistance. In one separate lecture, we will discuss all those. But remember 3 important hepatokines which are directly related with insulin resistance, and these are futin A, the fibroblast growth factor 21, FGF21, and retinol binding protein 4. These are the 3 main hepatokines which are related with developing insulin resistance within the liver. What are the early signs of insulin resistance in the liver? We understood that the insulin resistance starts within the liver. What are the early signs of insulin resistance in the liver? And these are, there's reduced insulin receptor expression. Then impaired glucose uptake by the liver and increased glucose production by the liver, and the accumulation of the lipids within the liver. So basically at the cellular level, what we see the reduced insulin receptor expression. Then we see on the glucose side, impaired glucose uptake and increased glucose production. It means the glucose is hugely produced, and its incorporation within the other components is reduced, and there is accumulation of lipids. So the consequences of liver insulin resistance. We understood that these are the four main signs of insulin resistance within the liver. What are the consequences? The consequences are there will be hyperglycemia, there will be hypertriglyceridemia, there will be muscle and MASH, and systemic insulin resistance. So once insulin starts, then the systemic impact at the impact on the body is the hyperglycemia, hypertriglyceridemia, muscle and MASH on the liver, and systemic insulin resistance. The chicken and egg problem. And what does it mean? Fatty liver or insulin resistance? Which comes first? This is important. Whether this is the fatty liver which leads to insulin resistance, or this is the insulin resistance which leads to fatty liver. Let's discuss this. There are three concepts or thoughts about this. One is the fatty liver leading to insulin resistance. Another school of thought is that insulin resistance leading to fatty liver. And then there is another thought, that is the co-evolutionary model. Let's discuss these. What does it mean? The fatty liver leading to insulin resistance, as shown by the light golden. What does this theory says? They say the story starts with the accumulation of the lipids within the liver. So the liver becomes fatty, and this leads to inflammation and oxidative stress. It leads to then insulin receptor downregulation and ultimately resulting in the insulin resistance. So the theory, which is in favor of fatty liver leading to insulin resistance, has four main steps: accumulation of lipids leading to inflammation and oxidative stress, leading to insulin receptor downregulation, and ultimately leading to insulin resistance. Then the theory which says that no, this is the insulin resistance leading to fatty liver, the blue, again it has got four steps. And what does it recommend or say? That there is impaired insulin signaling from any reason, by any mechanisms. The insulin signaling gets impaired. It leads to increased glucose production within the liver, leading to accumulation of lipids and thus resulting in the fatty liver. This is the second theory. But the well-accepted theory is that of the co-evolutionary model. It means the fatty liver and insulin resistance, they are interconnected with one another. Fatty liver versus insulin resistance, and insulin resistance versus the fatty liver. So in this they say because there's shared underlying factors for both, for fatty liver as well as for insulin resistance. The underlying factors they are shared, it leads to reciprocal feedback loop, and this leads to a progressive disease. So with the passage of time, the insulin resistance increases as well as the fatty liver severity increases. So now comes the question, how to break this triangle, breaking the triangle. This is the normal liver. And if a patient has got the insulin resistance, what happens on the liver side? 25% of the liver, when they become steatotic, 60% of those they develop NASH. And 41% of these they develop fibrosis. And the 22% of these they develop cirrhosis, and 2 to 3% of the cirrhotics they develop hepatoma. So it's a sequential process. Normal liver, the steatosis, NASH, which is characterized by macrophages and balloon hepatocytes. Then the fibrosis, where the hepatic cell stellate cells, they are activated. Then the cirrhosis and the hepatocellular carcinoma. So what is the cause of death in this whole sequence? This is the turning point. So the relative risk of death before fibrosis happening and after fibrosis happening, these are different. The risk of cardiovascular disease related death And then here is the risk of liver-related death. And we separate these with this milestone, that is the fibrosis. Before fibrosis happening, the major cause of death is the cardiovascular disease-related death. And as the process goes on, the risk is decreasing, while the risk of liver-related death, it is increasing. It takes over the chart at the level of the fibrosis. So when we see, and the study shows that if a patient, the insulin-resistant patient, if they have not developed the fibrosis, the major mortality is because of the cardiovascular disease. And when there is a fibrosis and cirrhosis, then the mortality is taken by the liver-related mortality as compared to the cardiovascular disease-related mortality. So, to sum up, there's metabolic stress in this whole triangle leading to systemic inflammation and fibrosis. And what organs are affected is the result of these? The vessels, the heart, the liver, the pancreas, and the kidneys. So because of this metabolic stress and systemic inflammation, what we see changes in all these 5 organs. On the vascular side, on the arteries, and it is manifested in form of hypertension, cardiovascular disease, and the coronary artery disease and peripheral vascular disease. Then on the heart, it leads to heart failure with preserved ejection fraction. Then in the liver, we see the MASD, metabolic dysfunction, steatohepatitis, steatoliver disease, and all the sequelae, the steatohepatitis, the fibrosis, the cirrhosis, and the cancer. On the pancreas, what we see? Type 2 diabetes. And on the kidney, we see the chronic kidney disease. So this insulin resistance, which leads to metabolic stress and systemic inflammation and fibrosis, all these 5 organ systems are affected, and these are the clinical presentations, how it can present. In one patient, it can present with chronic kidney disease. In other patients, can develop with type 2 diabetes. In the third patient, like MASLs, like heart involvement or arterial involvement, or it may be any combo, any combination, these 2, these 3, these 2, these 2, these 2, these. So it can be a variable presentation, but when we trace them to the origin, this is the origin, and these are the different pathways. So for the vascular side, what are the remedies? How we break the triangle? And when we break any one arm, the whole system collapses. This is important. So on the vascular and the arterial side, the role of the remedies lies in the weight loss, in the GLP-1 agonists, ARBs, statins, fibrates, and smoking cessation. While for the heart, again, weight loss has got its significant role. Then the SGLT2 inhibitors. Then on the liver side, again, weight loss, GLP-1 agonists. Then the SGL2 inhibitors, and of course the resmetirom. On the pancreatic side, again, weight loss, GLP-1 agonists, ARBs, the metformin, and the SGLT2 inhibitors. Similarly, for the kidneys, again, weight loss, GLP-1 agonists, ARBs, and SGLT2 inhibitors. So when you see the weight loss is the primary or is the common for all these, when you lose the weight, you have good impact on the arteries, on the heart, on the liver, on the pancreas, and on the kidneys. The second role is that of the GLP-1 agonists. Again, it affects the arteries, it affects the liver, the pancreas, and the kidneys. Similarly, the SGLT2 inhibitors, again, could impact on the heart, could impact on the liver, as well as on the pancreas and on the kidneys. So there are different modalities available, and they have got impact on one or more than one organs. So we break the triangle, we can break the triangle with the help of these, but remember, weight loss is the primary. So we can devise the strategy into three main steps. First step is early diagnosis and risk stratification. We should have a low threshold to diagnose this liver heart diabetes triangle, and then risk stratification. Then the targeted treatment approaches, we should be clear about it, and of course integrating multidisciplinary care. The early diagnosis and risk stratification means that the massal screening in diabetes and cardiac patients. Patients presenting to the diabetics and cardiac clinics, they should be screened for the massal. FibroScan and FIB4 should be incorporated into routine diabetic and cardiac checkups. When a patient goes to diabetologist or cardiologist, they must do the FIB4 screening and the FibroScan. Of course, and the cardiovascular risk assessment in MASL patient is also very important. If a patient with MASL presents to hepatologists, even in the absence of diabetes, should undergo routine coronary artery calcium scoring, echocardiography, and lipid profiling. This is very, very important. Then coming to the targeted treatment approaches, what are the options available? Lifestyle intervention. I showed you that the weight loss is common to all, is got a good impact on all 5 organs. So the weight loss of 7 to 10% significantly reduces liver fat, improves insulin sensitivity, and lowers cardiovascular risks. The Mediterranean diet, intermittent fasting, and resistance training have shown efficacy in receiving early stage MASL and metabolic syndrome. Similarly, pharmacological approaches and targeted treatment approaches are GLP-1 receptor agonists like semaglutide, liraglutide, and it improves glycemic control, reduces liver fat, and lowers cardiovascular disease. Similarly, SGLT2 inhibitors like empagliflozin, dapagliflozin, they reduce heart failure risk and prevent kidney dysfunction and provide metabolic benefits. Similarly, pioglitazone, it reduces NASH progression but has weight gain as a side effect. Statins, despite concerns about hepatotoxicity, they should not be avoided in MASL patients with high cardiovascular risk. Similarly, resmetirom. This is a wonderful drug, a liver-specific thymometic. It improves intrahepatic thyroid hormone receptor beta-2 signaling, and in clinical trials significantly improved liver inflammation, fibrosis, and lipid profile in patients with MASH. Coming to the integrating multidisciplinary care, there should be collaboration between hepatologists, endocrinologists, and cardiologists. It's essential for the optimal management, use of AI-driven predictive models, and clinical practice can help in early identification of high-risk patients. So these are the different ways. We know that for metabolic risk factors, these are the overweight or obesity, and there's a set adult criteria for these. Then dyslipidemia for type 2 diabetes, plasma triglycerides, HDL, blood pressure. So any risk factor, these are the different risk factors for the insulin resistance or metabolic dysfunction. So the metabolic dysfunction, it leads on the liver side, it leads to from the healthy liver to MASL to MASH and the liver cirrhosis and hepatocellular carcinoma. In the healthy liver, there is no fibrosis. In the MASL, again, no fibrosis. This is in the MASH when you see patients from F1, F2, and F3, and in the cirrhosis there is F4. The point is, coming to the semaglutide, the GLP-1, they are indicated in case of when a patient has got healthy liver, but there are the risks to become fatty or muscle are in the range from F1, F2 to F3. In all these ranges, the semaglutide is indicated. In F4, no robust data is there, so it is indicated in all these three stages. But on the other hand, the resmetirom, it's indicated in the clinic by the current guidelines in the F2 and F3 stage. So this is the difference when you will prescribe the semaglutide and when you will prescribe the resmetirom based on the current guidelines. So to sum up, the liver heart diabetes triangle, it's a deadly but preventable connection from fatty liver to diabetes to heart disease. And why integrated care matters? We have discussed all this. Why this triangle matters? The MASL is the fastest growing liver disease worldwide. Diabetes doubles the risk of cardiovascular disease, and the heart disease, it's the leading cause of death in diabetic and liver patients. And the triangle is the shared pathophysiology, that is the insulin resistance, inflammation, and dyslipidemia in all these three impacts. The interconnections, liver and diabetes interconnection, it leads to fatty liver, promotes insulin resistance. Then diabetes and heart, the hyperglycemia accelerates atherosclerosis. In heart liver, the heart failure worsens liver congestion and fibrosis. And it's a vicious cycle. One organ dysfunction worsens the others. So the breaking the triangle, early detection, screen for NAFLD, diabetes, and cardiovascular risk together. Lifestyle, including diet, exercise, weight management, it is a common prescription, and it should be for all 5 scenarios. And the medications, some drugs benefit all 3 systems like GLP-1 agonists, SGLT2 inhibitors, and statins. An integrated multidisciplinary approach is best patient's outcome. It is related with that. So just a clinical scenario. Patient, Mr. Khalid, 52 years old, and he presented as a known type 2 diabetic for 8 years, poorly controlled HbA1c 8.9, overweight, BMI 30, recently developed exertional chest discomfort, and routine blood test showed mildly raised ALT and ultrasound revealed fatty liver. So question to you, what is the most likely underlying link between his diabetes, fatty liver, and emerging heart disease? Please write your answer in the comments section below. The second question to you is, how would you approach his management holistically? Again, please share your answer in the comments section. Then why is it important to treat the triangle instead of only one medical condition? What do you think? Please do share your thoughts in the comment section. So the key takeaways, the liver-heart diabetes triangle highlights the critical need for a holistic, multidisciplinary approach in managing metabolic disease. Early detection, lifestyle modifications, and targeted therapies can significantly reduce morbidity and mortality associated with this interconnected disease spectrum. Future research should focus on precision medicine, exploring novel biomarkers, and personalized interventions to break this vicious cycle. You cannot treat diabetes and ignore the liver. Remember, you cannot manage the liver and forget the heart. The triangle survives or collapses together. Thank you very much for listening me, and I hope you are now clear what this triangle means and why we should be careful when a patient comes to us with either fatty liver or diabetes or heart disease, why the other components must be looked for and managed accordingly. Dear colleagues, as we move forward in managing patients, let's not treat the liver, heart, or diabetes in isolation. Let's recognize the triangle because breaking even one link can collapse the entire system. The feature of medicine is integrated, preventive, and compassionate. If we, as physicians, adopt a holistic approach, looking beyond single organs, we can transform outcomes for millions of patients. Remember, treating one organ may prolong life, but treating the whole triangle sustains it.